We
So,
move to the next speaker, Dr. Manavi. Are you here?
I'm here.
Manavi is like.
I'll share my now. Thank you.
In ophthalmology, especially with your retina, we have multiple scenarios with delay in triage. Every day, millions of people face emergency situations the world over. To ensure that they receive optimum treatment, triage is vital. In ophthalmology, especially with your retina, we have multiple scenarios where delay in availing treatment can result in irreversible vision loss. For improving follow-up for the patients with high-risk retinal conditions, we innovated the E1E2 emergency coding system. In the course of patient care, we noticed a significant problem. Patients requiring emergency care fail to avail the treatment on time, losing precious vision. Why does this happen? The doctors who are treating the patients have excellent knowledge about the patient's situation, but are they unable to convey the emergent nature? And what about the counselors who schedule the patient's appointments? They lack the depth of knowledge on the diseases and often, in a busy OP, counsel all patients in a similar fashion. Consequently, the patient does not understand his disease and the need for prompt treatment. Mixed signals are perceived from all the quarters and there is a delay in treatment. So, we went out to devise a solution for this problem. Not something complex, but easy and elegant. Born out of this dilemma was the E1E2 emergency coding system. Various diseases were coded into 3 categories and tabulated with their treatment options. This was made available to all the doctors and counselors. Coaching the counselors on these conditions enabled targeted counseling. The categories even included very high-risk cases like endophthalmitis, retinopathy of prematurity, retinal detachment due to giant retinal tears, who had to avail treatment within 1 to 4 days of consultation. E2, which covered a large majority of retinal diseases like proliferative diabetic retinopathy, age-related macular degeneration, retinal vein occlusion, were to avail treatment within 10 days. Category 3, including very few scenarios in which your retina, like SFI or surgeries, could avail treatment at their own convenience. The E1 cases, in addition to targeted counseling, received reminder phone calls on the day prior to their appointment and were followed up. In case of a missed appointment, they were tracked and reminded again. The E2 cases were tracked to check if they had availed treatment and received reminders only in case of missed appointments. As a result, over the course of 3 years, we saw that 80% of the E1 cases reported on the same day and 12% another day following a reminder. Similarly, a total of 96% of E2 cases availed treatment. The system is not without certain burdens imposed on the counselors. Increased counseling time, need to make phone calls, and manual tracking do add to their workload. Currently, we implement the E1E2 system across all our hospitals and continue to coach our counselors to improve their knowledge and communication. The strategy is also now integrated into our electronic medical record system and involves audio-visual or group counseling in some scenarios. This system can be further strengthened by the fully integrated EMR that sends automated reminders to patients and gives pop-up reminders to counselors. By working as a team, doctors, counselors, and patients can have a positive impact on visual outcomes.
So thank you, Manvi. I think that was a very organized presentation on, how to organize yourself and put them into various categories. Anybody has any questions?
Yeah, Manvi, congratulations for this very elegant way of actually triaging what is so important, what we actually tend to miss, especially in large hospital setups. I just had a question because it's a study that has really been very well followed up. So do you have a way in which you have categorized previously how it was done and now with your triaging system, how well it has fared? Is there any comparative analysis of the non-triad system with a triad system, which would really make it very, very strong in the sense that other hospitals should be able to emulate?
That's an excellent question, sir. And actually, way back in 2000, I mean, we have been following this system, and it's a part of our regular work pattern since 2013, mid 2013, when we innovated this. And at that point, about a year later, we actually thought of looking at this, But what happened is it's very difficult to derive this data retrospectively. So when we tried to do this in 2014, early 2015, what we realized is when we went to our hospital system and we tried to retrieve cases like proliferative diabetic retinopathy is one which you have high risk PDR in E1 and normal PDR in E2, or retinal detachment surgeries where macula on or GRTs fall in E1 and maybe a little older RDs could go into E2. And we actually tried to retrieve 1 year numbers of PDR case sheets coded in our system came out to be 40,000. And because the earlier case sheets were manual, and there was no coding then, we actually would have required to retrieve every case sheet, and a person who can understand if it's E1, E2 would like that would be a doctor, would have to sit and screen through those case sheets to see. And because of the large numbers, sir, we just couldn't do it. We tried to do it for retinal detachments, which itself, it was just not possible, sir. I think you can understand that. We would have loved to have that data, and I would have published it by now if I had it.
Thank you. Thank you, Manavi. I think we'll move on to the next.